This conference will now be recorded.
I am going to stop sharing my webcam so you can concentrate on the slides and on the talk. And I just wanted to let you know and introduce my partners here at the Sher Fertility Institute, Dr. Drew Tortoriello, who is the medical director, and my colleague, Kerry Deacon, and this is myself, and Dr. Levent, who is the director of the embryology laboratory. He is a director of several IVF laboratories in the country, having an enormous experience on the topic of today, which is egg freezing. So the objectives of today's talk are the following. We want to talk a little bit about what we call fertility preservation. What are the guidelines that have been established by the society that regulates us in part, which is American Society for Reproductive Medicine, current results in the world about egg freezing, and what we mean by elective or social fertility preservation. And we'll talk on the process, the potential risk, the results, and what recommendations, and there will be time for questions in the end. Now, for those of you that don't know too much about IVF, in vitro fertilization has been around for over 3 decades and is the most successful way to achieve a pregnancy when couples are confronted with problems. And in reviewing very, very briefly what IVF is, in IVF, what we do is we stimulate the ovaries, what we call control ovarian hyperstimulation, to grow eggs and mature eggs, and these eggs grow inside structures that we call follicles that we can see with ultrasound. And at some point, when we think these eggs are mature inside those follicles, we do a transvaginal follicular aspiration to harvest the eggs. And typically we inseminate the eggs with sperm, or most of the times today, nowadays, we do ICSI, or intracytoplasmic sperm injection, to fertilize each egg with one very selected spermatozoon, and then watch 5 days the embryos grow, divide, cleave, and become blastocysts, and transfer one blastocyst. So this is in vitro fertilization. Now, with the passage of time, we learned that we could freeze extra embryos. So this is embryo cryopreservation for future use. And this was over 2 decades ago. And also later on that we could biopsy the embryos to make sure about their chromosomal content. And this is what we call pre-implantation genetic diagnosis, or chromosomal diagnosis, ruling out things like Down syndrome and other chromosomal anomalies. Egg freezing came later because it was difficult for us to freeze eggs years ago. So the technology to freeze eggs developed much later, that's a few years ago, so that now what we can do is stimulate the ovaries, aspirate the eggs out, and freeze them. And we can freeze them anytime. And when the lady that has frozen eggs for a variety of reasons is ready to get pregnant, then we will go back to this process and thaw the eggs, fertilize them, and then transfer or freeze extra embryos. What is important here, therefore, is that once the eggs are frozen, the eggs will remain at the age of where the harvest happened. Now, fertility preservation in reality started when we looked at women, or we tried to help women that were at imminent loss of losing ovarian function, such as patients diagnosed with early stages on stage 1 and 2 of breast cancer, for example, or that we're going to be subjected to surgeries of the pelvis and lose the ovaries, severe endometriosis and others. And that's wonderful when we can do this in someone that will be subjected to chemotherapy and radiation, that we can extract and harvest the eggs and freeze them, and then patients can come back 4 or 5 years later once their cancer is in remission. And then we moved on into what we call elective or social egg freezing, which is basically preserving your youngest and healthiest eggs for later use. So this is a decision, it's an elective decision, or in couples that want to plan for multiple children, but they don't want to start until 30s, and or to have an alternative to IVF and freezing embryos. So this can be done at this stage. The woman doesn't need to have a partner because we can now freeze the eggs. And very importantly, egg freezing via this novel technique that is called vitrification is not considered anymore an experimental procedure, so it's a standard way to freeze that is approved by ASRM in the guidelines of 2013 and 2014, so we feel very confident about how it works. So you can see here in this diagram that in the beginning we did apply a process called slow freezing to embryos to get embryos frozen, and this didn't work with eggs. It worked very poorly. And in the last years, the new technology of vitrification allows us to have eggs that are frozen in a very fast way and with high efficiency. To give you a little cartoon here that brings you back to the winter time, the slow freezing for embryos used to be like this, very gradual drops of temperature from room temperature to minus 196. This was done by a computer in 4 hours. And it was found now that you can vitrify and in seconds bring the temperature to minus 196 without having the cell, the egg, suffer from crystal formation inside the cells that breaks the cells up. So vitrification is a wonderful way to freeze eggs. Now, keeping in mind that this is an elective process, women that want to freeze eggs need to understand that as any medical procedure, there are potential risks. I would say the risks are minimal for us that have been doing IVF for many, many years. So the ovarian stimulation is done with hormones called gonadotropins and some adjuvants. And typically what we want to see is multiple follicles growing. We have to prevent too many follicles growing or development of something called ovarian hyperstimulation syndrome that can lead to enlarged ovaries and pain, and other things can happen that puts a health risk into the process. And we are very careful how we stimulate. Particularly, these are going to be younger women that have a normal ovarian reserve, and therefore we try to very carefully stimulate them to avoid this risk. As a surgical procedure, I would say it's a minimal intervention with a needle that aspirates the follicles through the vaginal wall. So it's a very safe procedure, but again, anytime you go into an operating room and anesthesia is done, administered, there is a potential risk there. But again, with healthy women, the risks are very, very low. What is very important is these next 2 slides for you to understand what will happen. Because when we freeze eggs, we're going to keep the eggs frozen in liquid nitrogen under minus 196. And the number of frozen eggs will depend, we'll go into this next, will depend on ovarian reserve and age. ovarian reserve, and age will be the determinants of how many eggs a woman can freeze in a given cycle. Importantly, once the frozen eggs are kept and then when they months or years later will be used, the eggs are thawed at that time, and there will be a number of surviving eggs and a number of non-surviving eggs. But with vitrification, we are seeing over 90% surviving eggs. And the surviving eggs are fertilized with a sperm, and under typical conditions, these numbers of fertilization are over 80%. And the fertilized eggs are grown 5 days to the blastocyst stage, like we saw before, and then one blastocyst would be implanted, and other blastocysts would be vitrified. So the woman will have now extra vitrified blastocysts. And then one embryo leads to live birth. But none of these stages is a typical 100% success. So to give you an idea, these are results from our center. This is data from our laboratory here in Manhattan. The survival rate of frozen eggs is excellent, 99%, has been excellent. The fertilization is over 80%. And of those fertilized eggs, blastocysts will grow in 35% of the time. So 1/3 of fertilized eggs reach the blastocyst stage, which is the stage for implantation or freezing. And the implantation rate of these blastocysts is incredibly high, around 52%. And the live birth that we had in this number of cases was really good, really similar to fresh cycles, fresh eggs being used in IVF. But this is going to be very important, because the questions that you're going to have are going to be, okay, where do I fall in terms of my age and my ovarian reserve? And if I want to do this, how many eggs do I need to freeze? What would be the best number? So keep in mind that you start with a number of eggs, and the number of blastocysts is lower. And then this is also age dependent. If you freeze at the age 30, these numbers will be all better than if you freeze at age 40. So the two concepts are, number one, egg quantity, which leads us to talk a little bit about ovarian reserve. These are, not the eggs in the ovaries, but we talk about a biological clock, and some of the eggs are being lost without being used, but that happens naturally. If you look at this curve here, the number of eggs at birth is probably a few million in the ovaries, and at menopause, which is the end of reproductive life, it goes to 0. So there's a progressive, constant loss of eggs in the ovaries, and therefore that leads to an optimal time of fertility that would be between 18 and 32, 33. In the mid-30s, these numbers start going down, and then dramatically down 40 and over. So of course, now you will understand that if the reserve goes down, it's better to freeze as early as you make that decision. How do we measure ovarian reserve? How do we estimate ovarian reserve? Well, we do it every day in two ways. One is we do the transvaginal ultrasound in the beginning of a cycle to count these little antral follicles. These follicles measure 5 to 10 millimeters. So these are the first follicles that we can see with the ultrasound. And an average number, it depends on age, but an average number is 4, 6, 8 follicles per ovary. And there will be someone that has more of a polycystic-like ovary without having polycystic ovaries, and that will have 10 eggs 10 follicles, which will be 10 eggs per ovary. Or there will be someone that may have 1 or 2 eggs only, follicles. And of course, the prognosis is going to be very different. These women will have a lot of eggs, and in one stimulation, they probably have 15, 20 eggs, and they're therefore in perfect shape. And other patients that have fewer follicles may need to consider stimulating more than one time to have a minimum number. The second way we estimate the ovarian reserve is measuring AMH, is a hormone, anti-Mullerian hormone, which is made by the granulosa cells of the follicles inside the ovaries. The little follicles make AMH, so you would say immediately that a high AMH means many follicles. And if you look at where does AMH fall for my age, your age, a woman that is 30 to 34 has a median number level of AMH between 2 and 3.5. These are nanograms per milliliter. And younger women will have higher AMHs and will have higher antral follicular counts, and women that are older than 35 will likely have lower in numbers of AMH and a lower count, antral follicular count. You see, these are all ranges. There's no mathematical model to predict this, but between AMH and antral follicular count, we can really have a great estimate of what is the number of mature eggs that we will end up freezing in one stimulation. And we're typically very, very accurate with that. This slide shows, of course, that the recovered eggs by age goes down, and if you are in your 20s, an average with a big standard deviation is around 19 eggs. If you are 30 to 34, 14 eggs. If you are 35, 39, 10, 11 eggs. If you're over, lower. Therefore, the sooner a decision is made to freeze eggs electively, the better it's going to be. The other important factor is what we call egg quality. If you look at the IVF results in the United States per year that's published by SART, the Society of Assistive Reproductive Technologies, and you see this white line or yellow line, and this is age of the woman undergoing IVF, and this is the pregnancy success. And if you're under 32 years of age, you have a 40. These are live birth rates, So this is the best we do, around 40 to occasionally 50% live birth rates per single embryo transfer, but the obvious decline that happens with age, and women that are 40 will have a 20% likelihood of pregnancy, which is half at least what they had earlier. And this is just to compare with donor eggs. These are young women donating eggs to older women or younger women that have uterine problems. The success rate is around 50%, independently of the age, which really proves that it's the egg quality that matters and not the uterus in the end. So again, if you talk about ovarian reserve, and if you talk about age, to freeze eggs earlier is better than to wait. Now, one thing that happens, and this goes to the quality of the eggs, is that the embryo quality resulting from egg quality drops with age, so that the eggs in women that are in their 40s here will originate embryos that are aneuploid in many occasions. These are bad eggs. So if you are in your 40s and you have embryos, you can expect a majority of embryos that if you do the biopsy for the chromosomal analysis are going to be 80% abnormal embryos. And that's why we really suggest that if women do the IVF nowadays in this range, we analyze these embryos because you can have a lot of frozen embryos with expectation of births, and most of them will not make it. Mid-30s, 2/3 of the embryos are normal. Late 20s, 75% of the embryos are chromosomally normal. So again, better to freeze here than there. Now, this analysis of the chromosomes is not done in the eggs. Don't make me say this very clearly. This is done in the embryos. So when you freeze the eggs, because you are single and you don't want to get pregnant now, you want to postpone pregnancy for good reasons, you're not going to know about the chromosomal content until you fertilize them and you have embryos. And at that stage, once you have embryos, you can do this so-called pre-implantation genetic or chromosomal testing, which is called PGS today, where you have a blastocyst with a nice developed blastocyst. This is going to be the inner cell mass, which makes the baby, and this is the trophectoderm that is the placenta in the future. And you can, with a little laser, create an opening far away from the embryo and extract 5-6 cells, and then do a DNA analysis. Today, in a week, we know if this is a chromosomally normal embryo or is an embryo with a trisomy, is a Down syndrome, and of course we're going to transfer the normal embryo. Now that this technique is evolving so amazingly that we are already starting the analysis based on a new non-invasive method, which is based on DNA escaping from the embryo without having to do this biopsy, which is an invasive process. So it's a cell-free DNA that I think is going to probably be the way to go in the future. It's going to be incredibly successful. Results are showing equal results. This is an important slide because it shows that if you see in green, this is old-fashioned IVF with maternal age and implantation rate, as we know it in red, I'm sorry. We know that pregnancy or implantation rate goes down with age dramatically. But if you biopsy embryos, PGS, and you transfer one single embryo, you're going to have a great selection of embryos, and you're going to achieve a 65% live birth rate. And what really is incredible is that if you look across the ages, this 65% is maintained. Why? Because you have eliminated all the abnormal embryos. Obviously, women here are going to have more embryos and more normal embryos, and these women here are going to have fewer embryos and more abnormal embryos. But if they are lucky enough to have normal embryos, those embryos will implant as good as earlier. That's why this technology will continue to evolve. So in summary, elective fertility preservation works. It's not 100%, but it works very well. It's elective, and therefore you need to understand potential risks. There is a high likelihood of live birth, and of course this depends on age and depends on ovarian reserve, but more data are needed throughout the world to make sure that these are results that can be achieved all over the place. So the technique does not guarantee a baby. IVF never guarantees a baby, but definitely provides a very realistic chance to achieve a live birth. At the Sher Institute, we would be more than happy to see you. We have total dedication to our patients, 7 days a week. We have an incredible group of financial coordinators that will let you know everything you need to know about insurance and costs. and that's very important for egg freezing, because there are insurance carriers that cover egg freezing, but there are others that don't cover, or they don't cover the medication that has to be used to stimulate. And we will tell you all the facts on that. And furthermore, I'm sure that a question that will be asked is, okay, if my ovarian reserve is not as good as it should be, or ideally would be, how many times do I need to do this? Well, it all depends on the individual case, but in those cases, it's important that we do have also some packages to help women that need to have more than one stimulation. You can follow us on social media, Facebook, Instagram, our website, and I'll be more than happy to answer any questions you may have. Tracy, are we on?
Okay, I'm going to look. Hello, I'm going to unmute all of the lines as well so that people, if they want to talk, they can, as well as the chat is currently open for any questions that people may have. So there was a question that someone sent to me privately. Daco, how many eggs do I need if I want to have multiple children one day?
Well, like we said before, in the individual case is the individual case. We have to estimate the ovarian reserve, and we have to know the age, and then remember the efficacy or efficiency chart that I showed from eggs to babies. And I don't think there is any mathematical number, because you have to rely on age too, but we are happy to have anyone freeze around 15 eggs. And I can tell you probably that women under 35 probably will have 15 eggs, which will give them a realistic chance to have 1 or 2 babies. It's more difficult to predict in women that are 37 to 40 because of the quality of those eggs. So we would like to have more eggs and more embryos, but that may mean more stimulation cycles. So I think it all depends on the individual case.
Okay, there's a question here. Hello, I'm 40 years old. If I come in, would you discourage me from trying egg freezing?
I think that what I would definitely do is try to make sure that very quickly we estimate your ovarian reserve with the AMH, and we do an ultrasound to look at your ovaries and see that follicular count. And then decide, based on all the statistics we talked about, whether it is feasible and reasonable to stimulate more than once, probably 2 times, or maybe even up to 3 times. So we will not discourage someone that can have even 4 or 5 eggs. How long can the eggs stay frozen? As far as we know, anytime, years. We know for embryos, for example, our program had a pregnancy with 19-year-old frozen embryos. So there's no issue with the time.
Okay, the question was, I was a late bloomer, eat very healthy, and exercise very regularly. Do these factors matter in your general observation?
No, no. No, and it all comes back to analyzing right then, right now, the ovarian reserve and the AMH and the antifollicular count. We know that fertility is affected by many factors, but typically women that are trying to do this are not infertile per se, or they have never tried. So probably they are a group of women that have a good prognosis, health-wise and probably fertility-wise. And of the things that we would like to correct as much as we can are weight, both underweight and overweight. And very importantly, we are seeing that the use of long-term use of birth control pills may affect the ovarian reserve. So you may have to wait to reassess your reserve after stopping pills if the AMH is not high, according to the age. And smoking. Smoking affects ovarian reserve like very much.
Okay.
There was a question on the lab. Yes, the laboratory, all our services are here in Manhattan in the same place, and operating room, clinic, and embryology laboratory, andrology laboratory, everything is right here. And I want to say hi to Ihad, who is in Qatar, wonderful lady, embryologist, and I hope you're doing good. Thank you, Ihad.
Hi, Doctor. How are you? I missed you all. As I said, the best lab, the best doctors ever in the world.
Thank you, and I hope you're doing well.
You.
Yeah, I'm fine, Doctor. I missed you all.
Thank
We
you,
are
Ihad.
in quarantine now, working from home.
Yeah. Okay.
Yeah.
Great.
Thank you. We have one more question about our lab, and we are being asked if our lab is on site.
Yeah, the lab is on site. We have the premises here. We are in 5th Avenue and 38th Street, and we have a clinic here with ultrasounds and offices and embryology laboratory, storage of embryos, storage of eggs, operating room. Everything is here on site. So the embryos are not moved anywhere.
Excellent. Let me see. It looks like all of our questions have been answered. We want to thank everyone for joining our webinar. If you would like to call our office, schedule an appointment to meet with Doc O and discuss your fertility preservation, there's some information to call for an appointment or to visit our website today. We'd like to thank you all for joining. We would like to thank Dr. Oehninger for presenting to everybody today. Thank you very much.
Thank you.
Our webinar will be ending now. Thank you.